It's our honor to join you today. My name is Chris Moriates, and as was mentioned, I'm joined today by my colleagues, also hospital medicine physicians, Dr. Stu Schaefer and Dr. Mike Brode. And we are hospitalists at Dell Seton Medical Center in Austin, Texas, which is the fun part of Texas. You should come visit sometime. And Dell Seton Medical Center is a small hospital. It's we only have about 210 beds at our hospital. And as we'll describe, we, as you know, much of the world prepared for the COVID surge back in March, and started to get some patients towards the end of March with COVID, but really started to hit our surge later in the summer around June. And so I think we learned a lot as we sort of were able uh, to develop our structures and the way we approach this through March and April and May. And so we want to share with you today some of what we have learned and developed, particularly around, we were asked to describe what we've done around trying to decrease the number of lab draws that we do for patients in the hospital. And I just want to say, I mean, I know that those of you tuning in obviously believe in choosing wisely, but with COVID, sometimes we heard that this is the time we have to, do more and get more lab tests. And as you know, I think actually choosing wisely is more important than ever. And as we'll describe, if we can decrease the number of things like lab tests that are not helping people get healthy and not helping us take care of them, then we're able to decrease the amount of exposures, people going in the room, being exposed, and provide better care.
Thank you, everyone, for the invitation today. And really want to talk about how we structured this at our facility before we get into the recommendations. But briefly, we've developed a committee comprised of the main players who are taking care of our COVID-19 patients, including mostly at our hospital hospitalists, but of course infectious disease, our pulmonary and critical care doctors, but also pharmacy, and recognize that nursing leadership and our hospital leadership are extremely important in this process, and inviting subspecialists as we're learning more neurologic and cardiac complaints, we've invited them to participate and focused a little bit on developing consensus recommendations. Now that we're about 9 months into this, there are plenty of excellent resources through the WHO, NIH, writing guidelines even up to date. I'm not sure what you guys use in Brazil, but really the whole purpose of that is not necessarily are we going to create a whole book or guideline that is superior to these national organizations, but we want to focus on how to operationalize that and how that makes sense for our hospital. So really the committee's there to put what we think we should be doing into action. And I think, as I shared in the chat, you can have access to this. What we've done from it is develop guidelines trying to really say what we think is the best treatment and a little bit of the rationale for remdesivir, which we've been using, and then also too, the one that is no one can seem to agree on is the anticoagulation protocols. And so we've developed our own here, but realize there's a lot of variation among sites. And so it's an example of how we've just tried to operationalize it. And then I'll hand over to Dr. Schaefer.
Yeah, thanks, Mike. I think the key with the committee and why it's been such a success in helping us is that it's the key to us giving high value care. So we kind of are able to trim the fat, instead of everyone working in their own silos and doing their thing their own way. We can get together and streamline the process and make it easy, make it more efficient, come to terms with, what we don't need. And I think it's been just critical, in making, because really we're only as good as we're able to operate in our system, in our hospital. And so it's been crucial. So talking about lab monitoring, like Chris was saying, the first month, we ordered every lab in the book. I mean, we were spending a ton of money. We were ordering all of these labs because we were just scared. What do we need to know about these patients? We had just read the reports out of Wuhan, and we're getting every inflammatory marker and wondering what it could mean and freaking out about it. And then as, over the next couple of months, started to just focus on what was changing our management on these patients. And so, and we're able to kind of trim the fat and incorporate it into our order sets through our electronic medical record. So, so thinking about the rationale for these labs, kind of going through that on the bottom table. Obviously, our coagulation labs, we're still trying to figure out the utility of these. We know that coagulopathy can happen in COVID, and we know that they're at a higher both bleeding and clotting risk when these are abnormal. So we take that into consideration. These are probably the least helpful labs we get, and we're even considering if we should be getting these. So that's something we're going to be talking about. Obviously, CBC and CMP essential. The CRP we found really tracks well with the activity of the inflammatory phase of the disease. So, often we'll see it jump, and then a day later, our patient gets much sicker. So it's a kind of a clue to keep a more watchful eye on those people, expecting them to potentially decompensate, and that can help inform how we sign out and pass along patient care to our cross-covering night teams. And then we also see when it starts to come down a bit, it's usually a good sign, and it can help us, in terms of reassuring the patient that we expect things to get a bit better. So we've really found that to be useful. We don't track it every day. Every other day seems to be plenty. And obviously our EMR is capable of ordering every other day standing labs, and so we do that and it's just already in our order set now. So you don't have to think twice. You don't have to actually go in there and change it. It's already ordered to be spaced out. And if you want to make it more frequent, you have to actively do that. D-dimer, going back to the prior slide, we found this useful, obviously, in addressing how we're going to anticoagulate these patients. And then the thing that we've been getting better at, just anecdotally, is discontinuing it when we start anticoagulation, and that's something that I think is just, it's something that people just need to think about every day and get in the habit of discontinuing it. No reason to check it after because it's not going to change management once you start an anticoagulation, and you've maybe bought yourself 30 days of anticoagulation. Because we don't have any way of saying, if it goes up really high and then comes back down really quickly, that they're at any less risk than someone who stays persistently high for a few days. And we were ordering a lot of this early on, and I think with the idea that it could help us distinguish someone who just had COVID pneumonia and someone who had a superimposed bacterial pneumonia. But the data doesn't really support that very well, so we're moving away from that. That's why, at the top of the screen, plus minus, we haven't really found it that helpful. And so we're not making that part of our standard order set, and we're kind of moving away from procalcitonin, using other features like, asymmetric chest imaging, obviously a consolidation, the time course. Were they doing fine for 10 days, and then they got really sick? Other markers, other people that are just really sick on a lot of oxygen, we're probably going to put them on antibiotics versus someone on a couple liters. And so not using that as much. Troponin BMP just once when they get admitted. We want to understand whether they have myocarditis. We've seen a few cases of it. They might not always have, clear symptoms. They can just be dyspneic. And so we really want to know that up front. So that's been helpful, but we typically don't trend it anymore. We did it first, but there was just no change in our management. someone would get sick, their troponin would go up. Oh well, they're sicker. It doesn't mean anything. It means they have some demand ischemia, and we need to treat the underlying process. So stop checking that. And then initially type and screen when we were giving convalescent plasma. Right now we're not. We're trying to figure that out. So basically, the moral of this story is we started with getting everything, and then said, is this helping us? Is this helping our patient, or is it just wasting lab sticks? So you can see here, so Chris Moriarty's sent me kind of an inventory of all the costs of different lab tests. These are like estimated costs in US dollars. And, what was surprising me early on when, there wasn't much COVID, we were ordering respiratory viral panels, which cost, $5,000. I'm so glad we're not doing those anymore. Fibrinogen, such a waste. I mean, it hasn't helped. Correct me if I'm wrong, Mike and Chris, it hasn't helped me a single time with these patients. I don't think I've ever changed management. I don't think I've ever done anything differently. And so we're kind of moving away. It's $80. I mean, what's the point of that? Ferritin, it's high. We know that this person has COVID. Earlier on in the pandemic, when we didn't have readily available testing, and we just had to use our clinical suspicion, we were obsessed with getting all these labs because we were trying to put this viral picture together and try to understand what is our pre-test probability. Now our pre-test probability isn't as important because we can actually just test everyone and we have reliable testing. So a lot of these inflammatory markers we just cut out. And you can see, in terms of savings, labs to calculate an H-score, that's only for people that are in the ICU. I mean, with and without, you're saving a significant amount of money per patient. Next slide, please. Thank you. Yeah. So without the H-score, fibrinogen in those labs saving $107 on admission, that's not a small amount of money, especially when the hospital's stretched thin. Daily ICU, backing off from daily to every other day labs, and this adds up really quickly. And so I think the committee helped us very quickly back off and say, what is helping patients, what's not. It's fun to get tests to see how abnormal they are, but it's not helping anyone. And so that was kind of, I think, one of the best things we did early on, and it's saving a lot of money.
Yeah, and to continue what Dr. Schaefer was talking about, I think really too, in thinking about how we developed these labs and were able to reduce the amount that we were ordering, really focused on the whole point of this should be twofold. It should be initially predicting patients' risk for death or severe critical disease, and also to try to get an understanding of where they are in the disease process. And so created this graphic, but I think it's been more widely recognized that people start with a viral phase and then really move into the post-inflammatory phase where a lot of the severe complications and death usually end up. And so the labs are really focused in trying to differentiate, and same with symptom onset, whether they are just having viral replication or whether we have an exuberant host response that is going to lead to severe complications. So I think other places, I've served in a group looking at variation among other hospitals throughout the US, and it's extremely wide about what kind of labs they're getting. This is one from, actually, we're part of Ascension Hospital. These are the labs they recommend that we aren't currently obtaining. And the reason for this is a lot of the literature early out of Wuhan in China, and even large epidemiological studies of Europe and New York City have shown that these labs really do predict poor prognosis and are surrogates for the inflammatory response. But at the end of the day, what we really want to know is, what is this patient's risk of death, and are they having the inflammatory response? And what I would recommend for most people is using a risk stratification tool. There have been, I've seen about 8 or 9 developed, but this one came out, published in the British Medical Journal. It's from Oxford researchers in Britain. And it's the 4C mortality score. You can just Google it or type in this website. It's validated of 35,000 people and only includes 8 independent variables, which are pretty easy and clinical. The only non-routine lab, in addition to a CBC or BMP that it requires, is the C-reactive protein. And as you can see, the higher the score, it's almost linear, the higher risk of mortality. And if you just plug it in, it will pop up with a score. I took a 62-year-old man with a high inflammatory marker and has a 31% mortality based on this scoring. And that tells you basically all the information you'll need to know. I will say that there are some other tools developed. RDW has shown that a high RDW, which we don't typically look at, can be a sign in one study of a 31% versus 11% mortality. Early in the pandemic, there was a risk stratification tool out of China called the COVID-gram that used LDH. LDH and ferritin have been shown to be prognostic, but we don't routinely use them, and so it's hard to know. Same with like an IL-6 level. Is that a little bit elevated? Is that very elevated? Where I think we have now experience with the CRP, and that's much cheaper and widely available and gets you the same information you need. And similarly, you can just look at the chest x-ray or the bedside ultrasound to look at the severity of infiltrates and the number of quadrants that are affected, quite clearly related to the disease severity and the progression to critical illness or death. And so I think to kind of sum up, as we've been saying, these excess labs can be helpful and can tell us a little bit more information about the inflammatory state, but probably don't add anything to clinical gestalt or your overall impression of the patient, and especially where we're not using tocilizumab or any of these fancy medications to tamp down the immune response. We're just using dexamethasone when they have hypoxemia and require oxygen. It's probably not going to change management at all. And so we actually are discontinuing the labs once we've made the treatment decision. And so I'll just kind of leave this up as a summary and invite my colleagues to add a few closing words or open up for questions.
Yeah, thank you. Yeah, I think the bottom line, as we had mentioned, was, early on getting lots of different labs, and we created a structure within our own hospital in order to reach consensus amongst our group, and to continually question what labs and what practices in general. We're focused on labs today, but what practices are helping. And the biggest change we made that I want to make sure is clear is we changed from getting everyday labs to getting at least every other day labs, so once every 2 days, for our non-ICU patients. And that makes, I think, the biggest difference. So we're still getting a number of labs, as you can see. And my guess is that, 6 months from now, this might look very different. But the reason this will look different is because we have put in the structure and the practice to continually question and try to get rid of things that aren't being helpful. So I think that's the most important thing. And coming up with ways to decrease the number of tests we're getting that are not adding any value, and particularly, like I said, spacing them out when appropriate. And the last thing I'll say about that is we do track our outcomes. So, our mortality, our length of stay, and we actually at our hospital have had really impressive outcomes. Our mortality index was over the first wave here was at about 0.45. So about half the amount of people who were expected to die did die. and our length of stay was actually lower than the other hospitals in our area. And so we're analyzing now to show that the changes in our lab practices and other practices continue to result in those same good outcomes. But I think we all, completely, from what we've seen and what we know and what we believe, we are pretty confident that that's what we'll see, that, doing fewer lab tests continues to provide good outcomes for patients with COVID.